All right, here we are back with chapter 44. This is part 3. We finished up with part 2, or we ended off in part 2 anyway. We were talking about respiratory emergencies related to the pediatric patient, and we had begun a discussion about the different types of devices that we can use to manage a pediatric patient that is having some respiratory issues, or at least to be able to manage their airway effectively. We talked about the use of oxygen and as well as NP and OP airways and their use and contraindications, when we can use them and what kind of the pitfalls of that are. We'll pick up this discussion here kind of, essentially right where we left off, and talking about supraglottic airways. So these airways, of course, are used to provide positive pressure ventilation to patients who aren't breathing. So it's one of the many ways that we can provide a more secure airway. Of course, we're going to talk about the best way to make an absolutely secure airway here in just a minute. Of course, there are some issues with doing that. Supraglottic airways help to keep the airway open in these unresponsive patients who are either breathing on their own but need advanced airway support, or even those that are not breathing on their own that we need to provide a better managed airway. Of course, endotracheal intubation is kind of the gold standard, or the definitive, maybe not gold standard, but at least the most definitive way that we can ensure that we have complete and total control of the airway. But the issue with this is when we're dealing with pediatric patients, especially when we get down into infants, toddlers and infants, it becomes a much more complex endeavor with lots of other situations or lots of other things that we need to consider in that, such as the fragility of the airway and the tissues and everything in there that we're dealing with, and our inclination to want to kind of treat that airway with less genteelness and treat it much more like an adult airway. And it is very, very, very easy to rip and tear things in there. So we should really only consider endotracheal intubation if we're not able to provide adequate oxygenation and ventilation with good bag mask ventilation techniques, or if we're going to have a long transport time, or if it's going to be one of those situations where it's absolutely essential that we have total control of that airway. Just realize going into it that we can quite literally and easily cause more harm than good when we go to put an endotracheal tube in a patient if we're not very, very careful and very, very cautious. So keep that in mind. Supraglottic airway devices, they actually do a really good job to create a more secure airway and a lower chance of aspiration. So these are effective devices that we can use. They can and do still have a fairly high failure rate and complication rate, especially in the pre-hospital setting. So they're not absolutely perfect. They're not without their flaws. They can cause injury to the teeth and other parts of the mouth during insertion. Again, remember those tissues in toddlers and infants' oral pharynx is still fairly sensitive and tender and easily torn. There is still a risk of stomach contents being aspirated in the lungs. We can stimulate that vagus nerve during placement that can lead to a slow heart rate. And of course, taking too long to insert the device can cause low oxygen levels, which may also lower the heart rate. In some cases, they can raise the intracranial pressure, the pressure inside of the skull. If the device isn't placed correctly, it won't provide an effective airway. So there are some pitfalls. It's not an absolute perfect thing or an absolute perfect science to it. Supraglottic airways are indicated during cardiac arrest situations and when the patient isn't breathing and needs airway support. They can be used in cases of respiratory failure or even complete respiratory arrest, so it's not necessarily game off. They can be used for those. Patients with traumatic brain injuries may need them to actually help better protect the airway. Unresponsive patients who can't protect their own airway are good candidates for supraglottic devices, and they are helpful when a patient can't maintain an open airway on their own. If the patient needs prolonged ventilation, these devices are a good option. Remember, if we're just thinking that if we can correct a minor airway situation or a minor breathing situation to cause some course correction with, hypovolemia and low heart rate and those kinds of things, we're going to do a bag valve mask. But if it looks like this is going to be something that's going to be more long term, we can, and logically move on to a supraglottic airway. They can be used to give resuscitation medications through the airway when an IV or IV access isn't available. Of course, remember, this is not an ideal situation to be in, and those medications are far less effective when given through the airway route. It's important to remember that adult and pediatric airways are different and require different approaches. And I know I've said this multiple times, but it's really important that we realize that these airways are very fragile. They're very easily torn. It's surprising how easy it is to tear parts of the oropharynx, even in an adult, and in infants and children, and young children especially. Their airways are much softer, and of course the passages are smaller, and they don't have the cartilage and all those kinds of things that an adult airway does. So if we're going to have to perform a rapid tracheal intubation, we want to make sure that we've got our equipment ready. We're going to make sure we've got our pediatric specific equipment handy and ready, and then we've got various sizes and options and those kinds of things. And this is why most services will create a pediatric kit that is specifically made to have all of those elements that you might need in a pediatric intubation. So having that kit handy and having all that stuff handy is essential. You'll need a range of laryngoscope blades, typically sizes from 0 to 3. Endotracheal tubes you should have from about a 2.5 for premature infants up to even about a size 6 for large-sized toddlers larger sized children that are reaching that adult size. The correct tube size is usually chosen based on the child's age. Using that Braslow's tape is a good way to do it. Any size laryngoscope candle can be used, so you don't have to have the little small pediatric one. You can use an adult one. It just all kind of depends on kind of preference and best fit for you. Straight blades are helpful because they lift that floppy pediatric epiglottis and give a clear view of the vocal cords. The problem with curved blades or the Macintosh blades is we have a tendency to kind of try to force, we put that in the vallecula and we try to force that up. That's when we're going to start to rip and tear things, because that floppy little epiglottis that those guys have is not going to want to move as easily or as readily with that technique. So if you're using a Macintosh, you may still have to sweep the tongue and manually lift the epiglottis in those, even with the curved blade. So bear that in mind when you're using those. The correct blade size should extend from the patient's mouth to the tragus of the ear. So that's, it's very similarly in the way that we measure for an oral airway. A length-based resuscitation tape can also help you determine the right size of equipment that you need. For a premature newborn, use size 0 straight blade. For a full term and up to 1-year-old, use that size 1 straight blade. And for 2-year-olds to adolescents, we can use usually a number 2 blade on them, because that's going to give us enough of a range. For adolescents and older, we're going to use a 3 straight or curved, either one on those. Remember, like I said, we're gonna steer away from the curved blades for anybody under 2 years old, but it's not an absolute that you can't use one. But remember, you're not going to use it in the traditional way where you put it in the vallecula and you lift. You're going to actually lift the epiglottis with it. Otherwise, you're going to cause some damage in there. Length-based tapes are more accurate than using age-based formulas when choosing ET tubes for size, especially for patients up to about 77 pounds. Then they start to get off a little bit. So those length-based tapes are surprisingly accurate. Of course, nothing's perfect, but they are surprisingly accurate in helping you make those determinations of the tube sizes and everything that you're going to need equipment-wise. For infants up to a year old, use about a 3.5 millimeter uncuffed endotracheal tube. The reason why we're using uncuffed tubes in these 1-year-olds and younger is because, remember, their little tracheas don't have really strong rigid cartilage in them yet, and those cuffed tubes can actually cause damage, the cuffs on those tubes. And to be honest with you, their little airway is so small that you don't need a cuffed tube. It'll seal up around an uncuffed tube very well. So that the need for a cuffed tube is that the lack of a need for a cuffed tube is kind of twofold. First of all, it can easily cause more damage. Second of all, it's really not necessary and not needed. For 1 to 2 year olds, use a 4 millimeter uncuffed tube as well. Still kind of dealing with the same thing with them, with that tube actually sealing pretty well on its own, and the risk for damage. For little ones older than 2, calculate the tube size with this. You can use this formula. The 4 plus the age in years divided by 4 will equal the uncuffed tube size in millimeters. So generally speaking, we're going to use uncuffed tubes, under 2 years old. And honestly, the reason for that is their airways are just so much more fragile that we can cause more damage. We can use a cuff tube. It's not that we can't use them ever. So for infants, we'll use a 3 millimeter cuffed ET tube, and for children 1 to 2 years old, we'll use it a 3.5. But just realize though that there is, with using the cuff tubes comes a few more risks, and that may be why your service may or may not carry those. It may be a medical director's call on that. For children older than 2, we're going to calculate that cuffed tube size. Remember, we're going to use a different calculation for cuffed versus uncuffed. For cuffed size, we're going to use 3.5 times or plus their age in years divided by 4. That's going to give us our cuffed tube size in millimeters. Always make sure that you've got available one tube size smaller and one tube size larger than expected ready, in case the airway is narrower or wider than predicted. Sometimes that happens. For children 8 to 10 years old, it's best to use cuff tubes whenever possible. So generally once they reach about that age of 8 or 10, cuff tubes are going to be better for them, and the risk of us causing any damage or issues is greatly diminished with that age group, because things have kind of started to grow in place. They've got the cartilage rings and all that stuff are much more pronounced in their tracheas by that age. If there's a concern about swelling or airway trauma, the cuff can actually be deflated and not utilized. So you can put a cuffed tube in there and just simply not inflate the cuff, and that cuff could be used at a later time, potentially if it's needed. Cuffed tubes provide a better seal, which improves the connection between the ventilator and the patient. But as I've mentioned, they do come with some risks. If you overinflate the cuff, you can actually put pressure even on the esophagus as well, and potentially begin to separate the layers of the esophagus with too much cuff pressure or too much cuff inflation. Tube should be inserted about 2 to 3 centimeters beyond the vocal cords. Mark this depth at the corner of the child's mouth to guide placement. Uncuffed tubes often have a black glottic marker at the distal end of the to guide the insertion on that, because it doesn't have a cuff. It's got a little marker down there in place of the cuff, so you can see when you're in the right spot. Stop advancing the tube once the marker passes through the vocal cords. just like if it was cuffed. For cuff tubes, of course, we're going to stop when the cuff is just below the vocal cords. A general rule is to insert the tube to a depth that is 3 times its inside diameter. So to get you in the ballpark, if you have depending on your tube size, you'll just multiply that by 3, and that should get you pretty close to the depth that your tube should be. Pediatric stylets work for tubes that are sizes 3 to 6 millimeters, while adult stylets are typically used for 6 millimeter and up. Using a stylet's a personal preference, but if you do, ensure that the stylet stops at least 1 centimeter from the end of the tube. A stylet, if it sticks out too far, it can cause damage to the mouth or vocal cords or trachea. When using a stylet, bend the ET tube into a gentle upward curve. Sometimes bending the tube into more of a hockey stick shape can be helpful, and that's true with adults as well as pediatrics. So the process of preparing and performing that endotracheal intubation is going to start with us pre-oxygenating the patient with the bag mask device at 100% oxygen for 2 to 3 minutes before we attempt intubation. But we also want to make sure that we're avoiding hyperventilating. Remember, pre-oxygenating is not hyperventilating. Make sure the patient's head is in the right position, neutral for suspected spinal trauma, and of course sniffing position for those that don't have any trauma. Insert an airway adjunct if necessary during this process. And of course, if available, go ahead and put the heart monitor on them so you can kind of monitor their heart rate throughout the process. Use a pulse ox throughout the whole procedure, before, during, and after the intubation attempt, so that we can keep a close eye on those oxygen levels. And of course, capnography, you might have it handy so that once you have them intubated, you can watch the capnography on that too. Keep suction equipment nearby in case it's needed. And to properly perform this procedure, this endotracheal procedure, you can refer to skill drill 4.4-4 for a refresher on that, if you need a little bit of a refresher on exactly how to do that skill. Of course, if an intubated child deteriorates, use the DOPE mnemonic to identify the potential problem and institute the appropriate intervention. So if they start to go downhill, we want to check and see if that's displaced, maybe if it's obstructed, maybe there's a pneumothorax, or if we've got an equipment failure. That DOPE mnemonic kind of helps us to remember the things that we need to look for if they begin to deteriorate even though they're intubated. Some complications we might run into would be unrecognized esophageal intubation is a real problem. So if we get the endotracheal tube in the esophagus instead of the trachea, that's going to be a problem. Intubation may also cause vomiting and increase the risk of aspiration, just the process of us trying to intubate. Prolonged intubation attempts can lead to hypoxia. And of course, there is still the risk of potential damage to teeth, soft tissues, and other intraoral structures within their mouths. Orogastric and nasogastric tube insertion. When we can, there are instances where we do need to insert an NG tube. So positive pressure ventilation can often lead to air or liquid filling both the stomach and the lungs. Gastric distension can dramatically reduce the diaphragm movement and lower tidal volume, making ventilation more challenging. This makes it harder to ventilate the patient, and it requires higher inspiratory pressures. It increases the risk of vomiting and aspiration of stomach contents into the lungs. Invasive gastric decompression, like placing an NG tube or an OG tube, helps by removing stomach contents with a suction machine and therefore making ventilation much easier. This procedure, of course, is not recommended for unresponsive children with a poor or absent gag reflex and an unsecured airway. So it's not always something that we're going to use, but it is an option if the conditions are right. In order to perform this procedure, you're going to need the following: an appropriately sized NG or OG tube, 30 to 60 milliliter syringe with a funnel tipped adapter for manual removal of stomach contents through the tube, mechanical suctioning, adhesive tape, and a water soluble lubricant. So to prepare the patient, you're going to go through the following steps. You're going to select the appropriate tube size. We're going to use the pediatric linked base resuscitation tape to choose the tube size that is twice the size of an uncuffed ET tube. So if your linked base tape doesn't show you exactly what size of NG or OG tube to use, you're going to look at the uncuffed ET tube size, and you're going to go twice the size of that. A child needing a 5 millimeter uncuffed ET tube would receive a 10 French oral gastric or nasal gastric tube. Measure the tube on the patient. The tube length should be the distance from the lips or nostrils, depending on where you're going to place it, whether you're going to place it in the nose or the mouth, around the earlobe, plus the distance from the earlobe to the xiphoid process. So that's how you're going to measure the length of that you're going to need. And you're going to mark that length on the tube with a piece of tape so you'll know where you need to place that tube. When the tube reaches the stomach, the tape should align with the lips or the nostrils, depending on the route, and you should be in good shape. You can see this diagram right here kind of shows us how you measure the length for that. Place the patient in a supine position. Assess the gag reflex. If the patient is unresponsive with a poor or absent gag reflex, perform endotracheal intubation before placing the NG tube. The purpose of that is so that you don't push the NG tube down into the lungs. If you have the route to the lungs secured with an ET tube, then you don't have to worry about the NG tube or the OG tube actually going into the lungs instead of the esophagus and the stomach. For trauma patients, maintain appropriate spinal mobilization restrictions if a neck injury is suspected. If the patient has severe head or maxillofacial injuries, always go with the oral gastric route for inserting the OG tube. Lubricate the end of the tube for ease of insertion with with water-based lubricant. So then you're going to insert the tube over the tongue using a tongue blade if needed to help with insertion. Advance the tube into the hypopharynx and then quickly insert it into the stomach. If the child starts to cough, choke, or experience a change in voice, remove the tube immediately because you may have wound up in the trachea. Gently insert the tube. If you're going through the nasal gastric route, you want to gently insert the tube through the nostril, directing it straight back along the nasal floor. Avoid angling the tube upward. If the tube doesn't pass easily, of course, just switch nostrils and try the other side, or you may need to use a smaller tube, but never force it in there because it can kink and kind of bunch up in there. Advance the tube into the stomach. If you're unsuccessful, switch to the oral gastric route instead. Once you believe you have the tube in there, you can try to aspirate for stomach contents using a syringe with the appropriate adapter. So ideally what you want to do though first before you begin to try to aspirate stomach contents is you take your syringe and you fill it with about 10 to 20 milliliters of air. Put that tube on there. Listen over the upper left quadrant of the stomach and flush the air out of that, push the air into the NG tube and listen for a gushing or gurgling sounds. If you hear a gushing or gurgling sound over the right or left upper quadrant, then you know you're in the right spot. You got your NG tube in the right spot. If you don't hear that, then you're going to have to remove the tube because you're not going to get stomach contents out of it. Your tube's in the wrong place, it's kinked, or something else is wrong with it. So if it's in the right spot, secure the tube to the either to the nose or the cheek, depending on where you have it placed. Aspirate air from the stomach using a 30 to 60 mil catheter tipped syringe, or connect the tubing to a mechanical suction and set it on low, continuous suction, or you can use the intermittent setting. Depending on the size of the child, if it's smaller, if it's an infant-sized child, using a 30 to 60 mil syringe might do the trick just as much as anything else. Trying to suction the contents out of there, or get as much air out of there as you can. That's going to, our whole goal of doing this is to try to improve our ventilatory efforts with them. It's not necessarily to empty the contents of their stomach. We're trying to reduce the back pressure that we've got there, and more than likely, if we've been doing resuscitation or if we've been doing ventilations for a bit, it's probably air that's trapped. So getting that air out of there is really going to be helpful with our ventilatory efforts. Some complications, of course, as mentioned before, the tube can be accidentally placed into the trachea and lead to hypoxia. Of course, there's a risk of vomiting and aspiration of stomach contents even while we're putting an NG or OG tube in. Airway bleeding or obstruction can occur, and in rare cases, the tube may pass actually into the brain, into the cranium, the cranial space of the brain. That's more likely to happen with placing them nasally than orally. The oral route is a little more complex than the nasal route, but there comes with more risks with the nasal route as well, though either route can actually can result in tube placement into the cranium. When we're dealing with a pediatric patient in cardiac arrest, most cases are actually caused, and we've mentioned this many times before, by respiratory failure or shock. Usually it's one of those two things. Respiratory failure is oftentimes the first culprit in that, but it can be shock related, which can be related to any number of things, and we'll talk about shock here in a little bit. Sudden dysrhythmias require high quality CPR, recognizing if a rhythm is shockable, and of course, if it is, prompt defibrillation. So jumping on these and getting started is going to be super, super important. We're going to talk more about cardiac arrest in the pediatric patient in section 4. We'll get a whole lot deeper off into the weeds on that one. Section 4, maybe a tad bit on section 5 as well. We'll talk about that. So let's talk a little bit about assessment and management of shock in the pediatric patient. Of course, shock occurs when there's inadequate delivery of oxygen and nutrients to tissues in order to meet the metabolic needs of the body. There are 3 main types of shock that can affect both children and adults: hypovolemic, distributive, and cardiogenic. These are nothing new. These are the same shocks that you heard about back, early on in the paramedic program. So there's nothing new about these. It's just a bit of a different patient that we're dealing with. It's important to identify the cause of shock and quickly determine if the patient is in a compensated state or a decompensated state, because that's really going to drive some of the decision-making processes that we're going to make. In compensated shock, there are some critical abnormalities in perfusion, but the body is able to maintain adequate blood flow to vital organs by having redirected things from the periphery. This increases, we'll see increasing in the heart rate and increasing in vascular tone. The child may appear normal, but show signs like tachycardia and decreased peripheral perfusion, and which will show its head as kind of signs of cool extremities and prolonged capillary refills. Intervention, of course, is needed to prevent them from progressing into a state of decompensated shock. Now, decompensated shock is going to occur when the mechanisms to improve perfusion are no longer enough to maintain normal blood pressure, just like with an adult. It includes hypotension relative to the child's age. The child will be severely tachycardic and show signs of poor peripheral perfusion. There may be an altered appearance or altered cognition. Hypotension, of course, remember, is a late sign, and it is very concerning. It's a very ominous sign with these little ones. Initial management is going to involve positioning the child for comfort and providing supplemental oxygen. After the primary survey, transport decisions should be made based on the severity of the situation. How severe is the shock, or what did we find during that primary survey that's giving us an indication of what's going on? That's going to drive how much time we're going to be able to stay and spend there at the scene. Begin resuscitation on scene for any child showing signs of decompensated shock. And of course, remember, rapid transport of these patients to a facility that's going to be able to manage them is essential. Hypovolemic shock is, of course, the most common cause of shock in infants and young children. And it can be the result of fluid loss due to non-blood loss related things. Of course, it can be blood loss, but oftentimes we see it with vomiting, diarrhea, even heat stroke, and burns is another big one for that. Due to their small volume, excess fluid losses and poor intake can lead to shock quickly. Hemorrhage from trauma poses the same risk due to its vulnerability. Due to this vulnerability. So any one of these can lead to hypovolemic shock. The patient may have a normal mental status or appear slightly anxious. Early indicators of shock include tachycardia, pale or mottled skin, narrowing of the pulse pressures, and even cool extremities. Signs that the shock is progressing to a more serious state would include things like restlessness, decreased alertness, increased respiratory rate, delayed capillary refill, cool perfusion or cool skin, and hypotension. Of course, if we're trying to rule out the cause, maybe it's vomiting, diarrhea, those kinds of things, if signs of dehydration often show themselves as sunken eyes, dry mucous membranes, and poor skin turgor. Also with children under the age of 2, we're going to look at those fontanelles and see if those are sunken fontanelles. That'll be an indication of that they may be in a hypovolemic shock kind of a situation. Of course, we're going to allow the child to remain in a position of comfort. Give them some oxygen and keep them warm. Apply direct pressure to stop any external bleeding. And of course, volume replacement is going to be the primary treatment for children in hypovolemic shock. If they're in compensated shock, of course, what we're going to try to do, we're going to try to establish an IV or IO access en route, gather all the necessary equipment that you're going to start off with. We're going to use catheters that are preferably over the needle catheters in pediatric sizes of 20 to 22 or even maybe 24 gauge. If the over the needle catheter is unavailable, we can use the butterfly as a temporary alternative, but realize that the butterfly leaves that needle in there, and ideally we would be using a catheter with them. Common IV access sites in children are going to include the dorsum of the hand and antecubital fossa. Veins of the foot can also be used, and of course scalp veins. External jugular veins are available, but both of those, scalp and external jugular veins, are less commonly used just because of the difficulty sometimes with getting those, but sometimes a vein is a vein if you need one. Once you got an IV established, begin fluid resuscitation with isotonic fluids such as normal saline or lactated ringers. Start with 20 mil per kilogram boluses and reassess the status as you go. If it's possible, try to warm the IV fluids to help counteract the effects of systemic hypothermia caused by environmental exposure, blood loss, or even open wounds. Multiple fluid boluses may be required during transport to get them to a little more stabilized state. You should address the volume resuscitation separately from hypoglycemia though. For shock due to medical illness, perform a bedside glucose check and only treat with dextrose-containing fluids if the blood glucose level is low. Hypoglycemia is unlikely in shock due to acute injury. For children in decompensated shock, begin initial fluid resuscitation on scene. Evaluate what sites you can use for IV access. If you're unable to get an IV or it's unsuccessful, you can begin an IO infusion. Avoid IO infusions if a secure IV line is already in place, or if there is a fracture or possible fracture in the same bone where the IO needle would be inserted. Anything that can be administered through an IV line can also be administered through an IO line, which makes them a viable alternative. However, remember that trauma is going to create some unique situations that may prevent us from being able to use those. IO needles, most of these, there's different styles of these other than, the ones that are, you see this one here on your screen. There's a few different types of these, but they're typically double needles consisting of a solid core bore needle inside a sharpened hollow needle. The double needle is inserted into the bone, usually in the proximal tibia with a twisting or screwing motion, moving away from the joint to avoid disturbing the growth plate. So make sure you're far enough down that you don't mess up the growth plate. Once the needle passes through the bone, the solid part of the needle, the center part, is removed, leaving the hollow part in place. And then you can easily attach standard IV tubing to that catheter that's left in place. IO needles must be carefully immobilized since they rest, kind of that 90-degree angle from the bone, and they can be easily bent, damaged, or dislodged. So you have to make sure that you secure them very, very well. You're going to stabilize these things as you would any other impaled object in the body. I know it sounds kind of weird, but that's what we've done. We've placed an impaled object in our patient. We need to stabilize it like it's an impaled object. Complications that are typically associated with IOs are going to be things like compartment syndrome, a failed infusion, growth plate injuries, osteomyelitis, skin infections, bone fractures, those kinds of things. These are fairly rare things that happen, but they are potential complications. To properly establish a pediatric IO infusion, there's a skill drill that you can take a peek at. 44-5 will give you a quick review of that. And of course, when the fluid challenges or the fluid boluses that we're going to give, we're going to administer 20 mils per kilogram of an isotonic fluid via IO infusion, just like we would after in a regular IV. And then we're going to reassess that and repeat it as much as possible. As much as 3 rounds of that, or 60 mils per kilogram, may be required during transport to begin to see improvement in the blood pressure. Remember, these little guys have some pretty amazing compensatory mechanisms, so they can lose quite a volume of blood before they start to get decompensated. So it may take 60 mils per kilogram to start to see an effect on improved blood pressure, pulse rate, mental status, and even peripheral perfusion. Of course, in these situations, we're going to always provide rapid transport to a facility that can handle them. Distributive shock occurs when we have decreased vascular tone that causes vasodilation and what amounts to third spacing of fluids due to increased vascular permeability. This leads to plasma leakage out of the blood vessels and into the surrounding tissues. The result is a drop in effective blood volume, causing what we see as basically functional hypovolemia. Possible causes for distributive shock are going to include things like sepsis, anaphylaxis, adrenal insufficiency, and even spinal cord injuries. Sepsis is going to be the most common cause of distributive shock in pediatric patients. In early distributive shock, the child may have warm, flushed skin and bounding pulses due to the peripheral vasodilation. But as that shock progresses, we're going to start to see those signs and symptoms that'll resemble those of hypovolemic shock. Fever, of course, is a key finding in septic shock. In anaphylaxis, you may notice the urticaria or the rash and the wheezes. That's going to kind of give you an indication of that it's maybe anaphylactic related. And of course, neurological deficits may be present in shock caused by spinal cord injuries. The first line treatment for distributive shock, of course, is going to be volume replacement. that vasodilation that's happened, what we need to do is offset those fluids that have accumulated. So we're gonna try to replace or to fill those spaces up with some fluids. For septic shock, of course, we're going to give isotonic crystalloids or colloids of about 10 to 20 mils per kilogram. Epinephrine, norepinephrine can also be used to treat refractory septic shock, so if it's not responding. Dopamine may be considered if there aren't any other better options on the table, but realize that dopamine's going to be, things are getting pretty serious if we've gotten to the point that we're giving, epinephrine and dopamine and those kinds of things to try to counteract this shock. If anaphylaxis is present, provide emergency medical care that's appropriate for that, and that which would include epinephrine. So epinephrine for anaphylaxis is perfectly normal. It's a normal part of that treatment. Even giving Benadryl for that as well. However, for septic shock, that's where we've crossed a threshold if we're having to do that. The decision on when to establish IV access and transport for distributive shock patients follows the same guidelines for hypovolemic shock patients, and we're going to see them in kind of very similar ways, compensated versus decompensated. Adrenal insufficiencies can also lead to distributive shock. This may be due to a pre-existing condition like Addison's disease or adrenal suppression from chronic steroid use, those kinds of things. So along the way with these patients, there'll almost always be a history, when we're talking about a distributive shock situation. There's some kind of illness that's leading to a sepsis, there's an anaphylactic issue, there's an injury that's caused maybe damage to a spinal cord, and maybe there's a history of Addison's disease or steroid use and those kinds of things that's, kind of pointing us in a direction that's a little different than just pure straight up hypovolemic shock. These patients will benefit from fluids, but will also require a stress dose of steroids, the adrenal insufficient ones, to maintain circulation. So adrenal insufficiency, those might be the ones that we might actually give them a dose of steroids to kind of help cause a little bit of correction in there. Medical direction in these cases may order something around 2 milligram per kilogram of steroids IV, up to 125 milligrams for the adrenal insufficiency issues. Cardiogenic shock is caused by, of course, pump failure. Well, the myocardium function is impaired despite normal intravascular volume. So everything's working right vascularly, but the pump's not working right. This is a fairly uncommon thing, or actually a very uncommon thing in the pediatric population, but it's not completely unheard of. We might see cardiogenic shock in children with underlying congenital heart diseases, myocarditis, cardiomyopathy, and even certain rhythm disturbances. Recognizing that we're dealing with cardiogenic shock is crucial, as its treatment is going to differ from that of hypovolemic or distributive shock. Remember, hypovolemic and distributive shock we're giving fluids to. Cardiogenic shock, we're not going to do that. We're going to handle that a little differently. Some signs and symptoms we might expect to see: listlessness, lethargy, increased work of breathing due to heart failure and pulmonary edema, impaired circulation. They may have pale mottled cyanotic or clammy skin, abnormal pulse rates or rhythms, or findings of a murmur or gallop. They may even have an enlarged liver, sweating during feeding, or a history of congenital heart disease. Initial management for these patients is, of course, we're going to put them in a position of comfort, give them some oxygen, and prepare to transport to a facility that's able to manage their critical needs. When we're considering supplemental oxygen, in some types of congenital heart diseases, supplemental oxygen may not increase oxygen saturation. It may not help. Remember, we talked about some of those in a previous chapter where how the heart, some of the structures inside the heart post-birth hadn't closed off, so it's causing abnormal circulation. And because of that, it may not actually increase the saturation of oxygen in some of those situations. So not to say that you wouldn't give them oxygen, it just means that you may or may not see an effect of that in those particular cases. Parents may tell you this, so they may be aware of that as well and know that and share that with you. Establish an IV en route if possible, and of course treat the dysrhythmias that you may see because they may be contributing to that distributive shock. It's really important to distinguish cardiogenic shock from the other types of shock, hypovolemic and distributive, because treating cardiogenic shock like hypovolemic or distributive shock is going to cause a lot of problems. It'll cause them to worsen if they already have pulmonary edema, or it may cause the development of pulmonary edema to start. So it's really important to get a really good, accurate history of what you believe is going on with this patient before you start fluid resuscitation treatment in these shock situations. When in doubt, err on the side of fluid resuscitation unless you're sure of your diagnosis. So if you really just don't know, if you're like, I don't think it's cardiogenic shock, I'm pretty sure it's hypovolemic, maybe distributive, I don't feel like it's cardiogenic, so go ahead and treat with fluid resuscitation. But consider thinking about those things like the afebrile status, no history of volume loss, no history of trauma, and those kinds of things, and go, could there be a congenital heart disease issue going on here? But like I say, sometimes you just don't know. But if you do suspect cardiac dysfunction, administer a single isotonic fluid bolus slowly and monitor the patient carefully to fully assess the effect of that. If to confirm your suspicion of cardiogenic shock, what you might see after you give that fluid bolus is an increased work of breathing, a drop in oxygen saturation after they've received that fluid bolus, because that extra fluid is causing the heart to maybe work a little bit harder, or it's kind of getting spaced into the lungs and those kinds of things. So we may need to administer some inotropic agents to kind of push the heart along to make it contract harder, increase the contractile force, and improve perfusions. These, though, are actually very rarely administered in the field. So generally speaking, once you've said this patient is a cardiogenic shock patient, it's going to be all about transport. Getting them transported to a facility that's going to be able to manage their condition effectively. All right, so let's dive into some cardiovascular emergencies related to pediatric patients. Cardiovascular emergencies are relatively rare in children and are often caused by respiratory insufficiency or respiratory arrest, maybe even hypovolemia or infection. They're not typically directly cardiac related. During the primary survey, you should be able to quickly identify a cardiovascular emergency, determine its likely cause, and begin the life-saving treatment that is needed early on. Rhythm disturbances can be classified by pulse rate, so too slow, too fast, or absent. Pretty simple and pretty straightforward. Signs and symptoms are often non-specific. If a rhythm disturbance is suspected, quickly proceed through the primary survey, supporting their ABCs as needed. Get an EKG on them to help identify what that underlying rhythm is and to further guide what your next steps in management is going to be. Look for those reversible causes of those dysrhythmias, such as hypoxia and all of those H's and T's that may be present, or any one of those things that may be causing that you might be able to correct. The decision to stay on scene for additional history and secondary assessment depends on the child's overall physiological status. So how are they doing? Are they in bad shape, or do we have a minute to try to drill down in the history just a little bit to gain a little more information that might be helpful in the long-term treatment before we leave, because the parents may not make it to the hospital as quickly as the staff might need them to answer some of those questions. Bradyarrhythmias are most often occur secondary to hypoxia in children. First-line treatment, such as airway management, supplemental oxygen, assisted ventilations, is really, really helpful for these patients. So this is going to be where we can make the biggest impact with them. Less common causes of bradycardia are going to include things like hypothermia, congenital or acquired heart blocks, a toxic ingestion of beta blockers, calcium channel blockers, or even DIG. So those are less likely to have happened, but a good history is going to help kind of vet some of those things out. Elevated intracranial pressure can also cause bradycardia and should be considered in children with ventricular shunts or a history of injury. Suspect child abuse without consistent injury history. In bradyarrhythmias, you want to try to attempt to identify the cause of the bradycardia. If there is cardiovascular compromise, because this can occur if it's left untreated. Signs and symptoms of bradycardia may include acute changes in mental status, dizziness, fatigue, hypotension, lightheadedness, respiratory distress, or even heart failure. Shock and syncope are also not uncommon with these. Initiate electronic cardiac monitoring as part of the primary survey to assess the rhythm. In sinus bradycardia, the heart rate is slower than the lower range of normal for the patient's age, so take that into consideration. But healthy athletic adolescents may have sinus bradycardia as an incidental finding because they are so healthy, which is generally not something that is concerning. So it's not unusual for an athletic adolescent to have a bradyarrhythmia or a bradyarrhythmia that is perfectly normal for them and not really causing them any issues. Now, if we find an atrioventricular heart block, there could be a congenital or acquired, and these could happen and be present in varying degrees. AV blocks can result in disruptions to the heart's normal conduction system. First degree AV blocks are typically asymptomatic and often an incidental finding on the EKG, so it's not something that you get called for. You just happen to put them on there and you go, oh, hey, there's a first degree heart block. No intervention is needed unless there are significant signs of cardiovascular compromise. And treatment is only required when there is signs of hemodynamic instability or if the symptoms are getting worse. But we still should be looking for what may be causing that. This may be a symptom of something bigger going on. Second degree block can be present as either a Winky block, which is the progressive prolongation, or a Mobitz type 2, which we have a dropping QRS complex without the progressive PR interval elongation. So it can be a type 1 or type 2 second degree block. Type 2 is more serious and can lead to poor perfusion and cardiovascular compromise. So keep that in mind. Asymptomatic patients may not need treatment in the field, but symptomatic patients require careful assessment of their hemodynamic instability. If the child's heart rate is lower than 60 beats per minute with signs of poor perfusion despite adequate oxygenation and ventilation, we should immediately begin chest compressions and ventilations, as this is an indication of cardiac arrest or a near cardiac arrest event. Further interventions may be necessary depending on the child's condition and response to initial measures. This figure here shows an algorithm for managing a pediatric patient in bradycardia with a pulse or poor perfusion. These algorithms are really helpful in the treatment of these patients because they offer a quick reference and an easy to follow diagram or chart of what you need to do next. Tachyarrhythmias is defined as a heart rate that exceeds the upper normal limit for the patient's age. Tachycardia is categorized into two types based on the width of the QRS complex. We have narrow complex tachycardias, which is the duration is 0.09 seconds or less, and wide complex tachycardias is when the QRS duration is greater than 0.09 seconds. The significance of tachycardia should be evaluated alongside the patient's physical exam and medical history. Sinus tachycardia is common in children and can be treated and can be caused by things like fever, pain, anxiety, increased activity, exercise, but it also may occur as a compensatory response to hypovolemia, hypoxia, heart failure, and even medication effects. So we have to determine whether or not this is a normal response or a response to something normal, or if this is something that is more of a compensatory response that's going to require further attention. Here's the algorithm for tachyarrhythmias in pediatric patients. This will kind of guide your next steps. You can see it's a little bit more active or a little more complex than the bradyarrhythmias. Bradyarrhythmia is probably going to focus more on looking for respiratory causes and maybe some cardiac causes. Tachyarrhythmias, we're going to go kind of down a couple of different paths trying to determine what's causing that. So, treatment for tachyarrhythmias: if the child appears well, has a fever, and the monitor shows sinus tach, administering antipyretics, to break the fever is typically all that's going to be needed, and that may or may not be something that we do in the pre-hospital setting. For a history of significant vomiting, diarrhea, vomiting and diarrhea and those kinds of things, fluid resuscitation is going to be the recommended treatment for them. Narrow complex tachycardia. SVT is the most common tachydysrhythmia that requires treatment. The EKG will show ventricular rhythms with a narrow QRS complex that starts and ends suddenly. The heart rate is typically 220 beats per minute or higher in an infant and 180 or higher in a child, and this will remain fairly steady. The heart rate does not change with activity or stimulation, so rest, movement, activity, doing nothing, doing something, it doesn't really change. P waves are usually not visible due to the fast rate of it, the fast heart rate. In children without congenital heart disease, the history often doesn't explain the fast heart rate. So if they don't have a congenital defect, there's really no explanation of why this is happening. They may have a history of poor feeding or appearing a little off. Symptoms are going to include things like fussiness, pallor or pale skin color. Older children may report dizziness, palpitations, and even chest pain or discomfort. Signs of shock may be evident depending on the tachycardia's duration and its rate. Treatment for SVT is going to depend on the patient's perfusion and overall stability. If the child is stable, consider trying vagal maneuvers while securing an IV. Record the cardiac rhythm before, during, and after performing the vagal maneuver. Have the older child hold their breath, blow into a crimped straw, or bear down like they're having a bowel movement. For younger children, place an ice-filled glove firmly over the midface, ensuring the nose and mouth are not obstructed. Perform these techniques only once. If the child is stable but SVT persists after the vagal maneuvers, consider administering adenosine. Adenosine administration may lead to a brief episode of bradycardia, VTAC, or VFib, or even asystole, which will then spontaneously revert to a sinus rhythm. The persistence of any of these rhythms is uncommon. So typically these rhythms are short-lived and returns to a sinus rhythm. If the child is unstable, synchronized cardioversion is going to be recommended. The initial dose for synchronized cardioversion is going to be 0.1 or 0.5 to 1 joule per kilogram. Since cardioversion is painful, you should provide sedation to an awake patient before performing the procedure whenever possible. Of course, this is going to be protocol dependent. An alternative treatment for a child with SVT and poor perfusion is IV adenosine if vascular access is readily available, but you don't want to delay correcting that SVT if in a compromised patient to wait on vascular access. So we don't want to delay that synchronized cardioversion if the patient is unstable. Wide complex tachycardia. with a palpable pulse is likely to be ventricular tachycardia. This is rare, but very much a potentially life-threatening rhythm in children. VTAC may indicate underlying cardiac pathology. SVT can sometimes appear as a wide complex rhythm, so pay close attention to that. Differentiating between SVT and VT can sometimes be difficult. So, making that distinction between SVT and VTAC may not always be super clear. So print you off a strip and look at it closely. If the child is stable and the IV is available, consider administering a adenosine IV to help distinguish between SVT and VTAC. The patient's ventricular rhythm should be regular and monomorphic. If the rhythm persists, consult medical control before proceeding with further pharmacological treatment. If the patient is hemodynamically unstable, perform synchronized cardioversion using the same energy level that you would for SVT. If the child is pulseless, initiate CPR and follow the pulseless arrest treatment guidelines, and prepare for immediate transport of any child with a serious dysrhythmia. The survival rate of a pediatric arrest in the pre-hospital setting, unfortunately, is very low, with few survivors having good neurological outcomes. So even the ones that survive don't always have really good neurological outcomes. Most out-of-hospital pediatric arrests are not witnessed, with only about 30% of the children receiving bystander CPR before EMS arrival. The most important factor is to deliver high-quality CPR to these patients. Attach a monitor or defibrillator to assess an underlying cardiac rhythm and defibrillate those rhythms as needed. Pulseless VTAC or VFib, of course, the treatment for that is going to be defibrillation. Additional interventions should be to establish vascular access, administer epi, and consider the administration of an antidysrhythmic such as amiodarone. Asystole and PEA, defibrillation is not needed. Additional treatment is going to be to start an IV, administer epinephrine, consider inserting an advanced airway. After giving the medication, of course, we're going to perform 5 cycles of CPR before reassessing that rhythm. If asystole or PEA continues, we're going to continue with CPR and administer additional epinephrine. This right here shows the algorithm for pediatric tachycardia with a pulse algorithm. And it kind of runs you down through that. It's a lot of information there on the right-hand side of that. Hopefully, I know you guys will be taking, pretty soon be taking the PALS course. And this PALS course is going to cover these algorithms in a more in-depth way. And of course, then you're going to get some time in the lab to begin practicing your cardiac arrest rhythms in pediatric patients. So that, boom, is the end of part 3. Part 3 is the halfway point for chapter 44. So we're halfway through it. I will see you all back in part 5.